Imagine you're looking a patient in the eye, right? And you're telling them they have cancer.
Right.
And then, you pull up their PT scan and you're expecting to see exactly where the disease is hiding, but the screen is just entirely dark. Like nothing is lighting up at all.
Which is terrifying for a clinician, honestly.
Yeah. And for decades, I mean, a dark scan felt like this massive failure. Or even worse, it gave clinicians this false sense of security, leading them to conclude the cancer was just gone.
Exactly. But today, well, we know that a dark scan might actually be telling you something even more dangerous about how that specific tumor operates.
It's wild. So welcome to this deep dive, everyone. Whether you are, a medical student cramming for your boards, maybe a junior clinician trying to really upgrade those diagnostic instincts, or just someone fascinated by how we decode the human body.
You're definitely in the right place.
We are opening up just an absolute masterclass of a text today. It's called Phenotypic Oncology, PET, an instructional casebook by Qingyi, Oliver, Wong, and Wong Wu.
It's a fantastic resource. Really groundbreaking stuff.
It really is. And our mission today is to just completely dismantle that binary way of looking at a positron emission tomography scan or, a PET scan.
Right. We have to stop asking, is it positive or negative?
Exactly. We're going to start reading these scans as dynamic living maps of tumor biology. We are looking for what they call their phenotypes.
Because to really understand phenotypes, you have to look past the hardware of the scanner itself.
Right.
You have to focus on the cellular machinery that's actually driving the image.
Right.
I mean, a scan isn't just a photograph, it's a metabolic footprint.
A metabolic footprint. I love that.
Yeah, we're measuring what the cells are actively consuming, what receptors they're building on their surfaces, and just how aggressively they're dividing.
And I think that leads directly to the author's most foundational rule, which honestly, it kind of shatters a massive misconception in the medical community.
The idea of the false negative.
Yes. They argue there is basically no such thing as a biological false negative PET scan. Every single tumor expresses this unique spectrum of tracer uptake.
Right. So if a known tumor is dark on an FDG scan.
And FTG, just to clarify for the listener, that's the radioactive glucose, right? The sugar tracer.
Exactly, the sugar tracer. So if it's dark on that FDG scan, it didn't hide from the scanner. It is actively giving you critical data about its biology.
Okay, let's unpack this with the lymphoma examples they give in the book.
All right.
So a low-grade lymphoma, that's composed of cells that are multiplying, but, at a relatively sluggish pace.
They're taking their time.
Right. And because their division rate is so low, their demand for ATP, the cellular energy, is also really low.
So when you inject that radioactive glucose tracer, those low-grade cells, well, they simply don't need to eat very much of it.
They're just not hungry.
Right. And on the scan, the tumor appears faint or even completely dark.
Wow. And then you contrast that with a highly aggressive, high-grade lymphoma.
Which is a totally different beast.
Yeah, those cells are just dividing out of control. They are starving for energy, so they literally gorge on the tracer, and they just light up brilliantly on the screen.
So that dark scan, it's not a mistake. It is an accurate biological signature of a slow-growing disease.
Right.
And the authors point out the exact same mechanism happens in lung cancers.
Oh, right, with the adenocarcinomas.
Yeah. If you have a well-differentiated adenocarcinoma, those cells, they still somewhat resemble normal functioning lung tissue.
Like they haven't completely forgotten their original day job?
Exactly. They haven't completely lost their identity, so they aren't entirely consumed by just rapid, mindless division.
Yeah.
So they take up less sugar.
But a poorly differentiated cell, like, what is it, a sarcomatous lung cancer?
Yes, sarcomatous. That type has lost all its specialized function. It only knows how to multiply.
And that requires massive amounts of glucose, so it lights up like a Christmas tree.
It does. And we really have to factor in how modern imaging actually works in the clinic. Clinicians are almost always looking at fused PPCT scans now.
Right, so it's a combination.
Yeah, the CT portion, the computed tomography, that provides the anatomical structure. You can physically see the mass occupying space in the lung on the CT side of the screen.
So you already know it's there.
Exactly. You don't need the PET tracer to light up uniformly just to prove the mass exists.
Right.
If you see a structural mass on the CT, but there's low glucose uptake on the PET, you now have this vital piece of phenotypic data. You know you're dealing with a tumor operating at a much lower metabolic gear.
Okay, it's like looking at a thermal camera of an industrial city block, right?
Okay, like this.
So if the standard satellite map shows a massive building, but the thermal camera shows that building is completely cold. Well, the thermal camera isn't broken.
Right.
It's not a false negative for a building. It's just telling you, hey, this structure is a cold storage warehouse. It's not a blazing, overheated steel mill.
That is a perfect analogy. You're getting a completely different layer of functional information.
And that functional layer is really the core of phenotypic oncology, isn't it?
It absolutely is. It allows the diagnostician to move beyond just locating the disease. You're actually characterizing its behavior in real time.
But, I mean, understanding that metabolic appetite, that introduces a pretty massive clinical challenge.
It does, because if tumors eat differently, then using the exact same radioactive sugar tracer for every single patient.
It's a fundamental error. I mean, if the thermal camera only ever looks for heat, you're going to miss a ton of vital information.
Right. We have to match the chemistry of the tracer to the biology of the tumor. It's a lock and key mechanism.
Okay, so let's talk about the lock and key, because the book highlights this fascinating scenario where this concept just flips our entire understanding upside down.
Ah, the neuroendocrine paradox.
Yes, this blew my mind. So based on what we just talked about, if you use a standard FDG glucose tracer, a low-grade neuroendocrine tumor is going to be dark because it burns sugar slowly.
Yep.
And a high-grade tumor will be bright because it burns sugar quickly.
That's the standard logic.
But the authors show that if you take that exact same patient and use a different tracer specifically, gallium-68 or copper-64,
Dotatate. Right.
yeah, dotatate, the visual pattern completely reverses. The low-grade tumor lights up and the high-grade tumor goes dark.
It's incredible to see on a scan.
Right. But if I'm a clinician looking at a patient's chart, and one scan says the tumor is highly active, and another scan of the very same tumor says it's practically invisible, I mean, how does a clinician synthesize that without just getting paralyzed and second-guessing their whole treatment plan?
Well, you synthesize it by understanding what the tracer is actually measuring.
Okay.
See, FDG measures glucose metabolism. But dotatate, that doesn't measure metabolism at all.
Wait, really? What does it measure?
It measures the expression of somatostatin receptors.
Somatostatin receptors. Okay.
Now, think of these receptors as like tiny catching mitts situated right on the outside of the cell membrane.
Okay, catching mitts.
Well-differentiated, low-grade neuroendocrine tumors, they're just heavily coated in these mitts.
Ah, I see where this is going.
Right, so when the dotatate tracer is introduced into the body, it binds perfectly to those receptors, making the low-grade tumor incredibly bright on the scan.
And because they are low-grade, they aren't eating a lot of sugar, so they're dark on the sugar scan.
You got it. Now, look at the high-grade tumor. As those cells mutate and become more aggressive, they go through this process called de-differentiation.
Meaning they lose their specialized features.
Exactly. They shed those specialized features, including the somatostatin receptors. They literally lose their catching mitts.
Wow. So the dotatate tracer just has absolutely nothing to bind to?
Right, making the high-grade tumor completely dark on that scan. But because they're multiplying wildly, they gorge on the FDG tracer, making them super bright on the glucose scan.
That is just a brilliant diagnostic tool. So by running both, you aren't getting conflicting information at all. You are mapping two entirely different biological pathways.
Exactly. You're seeing the structural receptors on the outside and the metabolic furnace on the inside.
And this precise pairing of tracer to phenotype, that gets super critical when we look at prostate cancer, right? Cases 30 and 84 in the book really dive into this.
Yes, prostate cancer is notoriously tricky because those cells are really slow glucose consumers.
So an FDG scan is basically useless there.
Often, yes. So let's look at a scenario. Say a patient has a rising prostate-specific antigen, or PSA, level in their blood.
Which suggests the cancer is returning or maybe spreading.
Right. Now, historically, the very next step is a standard technetium-99-meter bone scan, just to check for metastasis to the skeleton.
But the book points out this massive trap here for modern clinicians.
A huge trap, because most of these patients with rising PSA are already on androgen deprivation therapy, or ADT.
Right, and ADT systematically starves the body of testosterone, which, prostate cancer needs to grow.
Exactly. And it is highly effective at shrinking tumors. But it fundamentally alters the bone microenvironment.
How so?
It actually suppresses the specific osteoblastic bone reaction that standard bone scans rely on to generate any kind of signal.
Wait, so the metastasis could literally be sitting right there physically in the bone, but because the ADT altered the local chemistry?
The standard bone scan is rendered entirely blind. It'll just come back totally clear.
Wow. So the bone scan is blind and the sugar scan is blind because prostate cells don't eat enough glucose.
Which is exactly why you have to swap the key to fit the lock.
Right.
The clinical protocol now dictates using a prostate-specific tracer, something like F18 fluciclovin or F18 PSMA.
And PSMA stands for prostate-specific membrane antigen, right?
That's right. These tracers, they don't care about glucose metabolism or bone reactions at all. They are engineered to bind directly to the specific amino acid transporters, or the specialized proteins, that are overexpressed exclusively by prostate cancer cells.
So you just bypass all that environmental noise and target the tumor's unique fingerprint directly.
Exactly.
And we see that exact same targeted logic in case 85 with thyroid carcinoma.
Oh, the iodine-131 scans.
Yeah, iodine-131 SPECT-CT whole body scans. Because thyroid cells are biologically programmed to absorb iodine from the bloodstream, right? That's just how they produce hormones.
Right, so their natural function.
So by attaching a radioactive isotope to iodine, you essentially trick the thyroid cancer cells, whether they're in the neck or, metastatic nodules hiding in the lungs, into literally pulling the tracer inside themselves.
It perfectly visualizes their specific cellular appetite.
Yeah.
It really is an elegant science.
There really is.
But, there's a secondary challenge here that tests the clinical instincts of basically every diagnostician.
Okay, what's that?
What happens when you have the perfect tracer, right? You run the scan, and the patient's entire body lights up like a supernova, or maybe displays these terrifying dark voids for reasons that have absolutely nothing to do with the cancer.
Oh man, the battle between signal and biological noise.
Exactly. We're talking about avoiding major clinical pitfalls.
Yeah, the authors provide some incredible case studies of these false alarms. Like case 46 is a prime example of this.
The exercise case.
Yes. So a patient comes in for a standard FDG PET scan, and the resulting image shows this immense, heavy tracer uptake across nearly every skeletal muscle in their entire body.
At first glance, it looks like widespread catastrophic disease.
Right. But the underlying cause was purely physiological. The patient had engaged in vigorous exercise shortly before the scan.
We really have to look at the cellular mechanics of a workout here.
Let's do it.
When you exercise, your muscle fibers require immediate energy. So your body releases insulin, which acts as a chemical key, unlocking the muscle cells and driving glucose from the bloodstream straight into the tissue.
And because our tracer is literally a radioactive glucose analog, that natural insulin drive violently pushes the radioactive tracer right out of the blood and heavily into the muscle.
The scan is flawlessly capturing the biological aftermath of the workout.
That's crazy. It just reinforces that a diagnostician cannot interpret an image in a vacuum, The patient's immediate behavioral history is just as critical as the physics of the scanner.
You literally have to ask them during intake, did you do push-ups this morning?
Right. And there's an even more recent phenomenon covered in the text, too, the COVID-19 vaccine effect.
Ah, yes, that caused a lot of confusion recently.
I bet. The book notes that recent vaccinations cause highly confusing phenotypes, particularly something called reactive adenopathy.
Right, reactive adenopathy, that's essentially the swelling and hypermetabolic activity of your lymph nodes.
Okay.
Because lymph nodes are essentially training camps for your white blood cells.
Training camps, I like that.
Yeah, so when you receive a vaccine in your arm, the local lymph nodes in your armpit go into absolute overdrive. They're manufacturing and training immune cells to recognize those viral proteins.
And that manufacturing process requires immense energy.
Massive energy. So those specific lymph nodes just consume huge amounts of the FDG tracer.
Which means if a clinician doesn't check the patient's vaccination history, they might look at that brightly glowing lymph node near the breast or the lung and totally misdiagnose it as a metastatic tumor spread.
Exactly. The immune system is doing exactly what it's supposed to do, but it's creating terrifying noise on the scan.
Wow. But noise isn't always bright, right? It can also manifest as dark voids.
It absolutely can. In case 78, they explore primary CNS lymphoma.
Right, the brain scan.
Yes. You look at an FDG PET scan of the brain, and there is this pronounced area of hypometabolism, a completely dark region where the brain tissue just isn't consuming any energy.
And a junior clinician might look at that void and just assume the tumor has necrotized or, killed off that entire section of the brain.
Right, but you have to cross-reference the data. When they pair that dark PET scan with an MRI, the MRI shows low-density changes in the exact same location.
So the dark area isn't dead brain tissue?
No, it's vasogenic edema.
Vasogenic edema. Can you break down why that happens?
Sure. So a growing tumor creates physical mass, right?
Right.
And because the skull is a closed box, that mass has literally nowhere to go. So it pushes outward against the surrounding healthy brain tissue.
Just sheer pressure.
Exactly. And this pressure disrupts the blood-brain barrier, causing fluid to leak out and flood the area. That fluid is vasogenic edema.
Okay, I see.
And that fluid buildup physically squishes the healthy neurons,
Mhm.
inhibiting their ability to metabolize glucose. So the dark spot on the scan is simply the collateral damage of the fluid pressure. It's not the actual boundary of the tumor itself.
That is wild. And, case 45 shows another fascinating version of a dark void, but this time in a pelvic sarcoma.
Right, the central photopenia.
Yes. The scan reveals this massive glowing tumor, but directly in the center is a complete absence of tracer uptake, a literal black hole in the middle of the mass.
And in the context of aggressive sarcomas, that central photopenia points to a biological failure of the tumor itself. It points to necrosis.
Right, the tumor is dying?
Parts of it, yes. Sarcomas can multiply so rapidly that their cellular division actually outpaces their angiogenesis, their ability to build new blood vessels.
Oh, wow.
So the outer rim of the tumor is close to the host's blood supply. So it survives, it eats glucose, and it glows on the scan. But the core of the mass is starved of oxygen and nutrients.
So it just dies off and goes dark. It grew so fast it literally choked itself.
Precisely. And what's interesting is, in that same patient, the scan picked up a tumor embolism in the inferior vena cava.
Which is the main vein carrying blood back to the heart, right?
Right. The tumor was literally shedding physical clumps of cells directly into the bloodstream.
Which really perfectly illustrates the mechanical reality of how cancer actually spreads. And it sets up a vital clinical rule from case 1 in the book.
The pulmonary nodule rule.
Yes. A patient presents with 2 distinct pulmonary nodules on their scan. And the authors state this pretty sobering statistic. If you spot a second pulmonary nodule, there is an over 50% chance it is metastasis.
That's right.
But the book throws out that stat, and I want to look at the why behind it. Like, why the lungs? Why is a second spot there so uniquely dangerous?
It really just comes down to plumbing. Yeah. The entire blood volume of the human body pumps to the capillary beds of the lungs every single minute.
Every minute.
The lungs are this massive, dense biological filter made of microscopic blood vessels. So if a primary tumor anywhere in the body sheds a clump of cells into a vein, like that sarcoma shedding into the vena cava,
Right.
those cells travel up to the heart and are immediately pumped right into the lungs. And the lung capillaries act like a net, trapping those circulating tumor cells.
So statistically, if you see a new separate nodule suddenly appearing in that pulmonary filter, the odds are incredibly high that the primary disease has breached the bloodstream.
Exactly. It turns a static statistic into a mechanical reality.
It makes perfect sense when you visualize it like that. So once we understand how tumors spread and, we've learned how to filter out the noise of gym workouts and vaccines, we reach the most advanced application of phenotypic PET in the book.
Tracking the timeline of the disease.
Right. We're talking about using exact quantification to measure if a therapy is actually working over time or to map these really complex systemic disorders.
Because when a patient undergoes chemotherapy or radiation, we aren't just hoping the tumor physically shrinks on a CT scan.
Right. We want to see a fundamental biological shift.
Exactly. We want to see the dense population of hyperactive tumor cells get replaced by fibroblasts, which essentially form scar tissue, or by recovering normal cells.
And scar tissue metabolizes glucose at a drastically lower rate than a malignancy.
It does. So by calculating the exact numerical drop in that tracer uptake, clinicians can perform true objective response assessments.
But man, the neurology cases prove that post-therapy biology is incredibly tricky.
It really is. Case 42 is a prime example of this.
Yeah, the one dealing with the central nervous system, specifically post-transplant lymphoproliferative disorder, or PTLD, and diffuse large B-cell lymphoma.
Right, so PTLD is this severe complication that can happen following an organ transplant.
Because the patient has to take heavy immunosuppressive drugs to prevent their body from rejecting the new organ, right?
Exactly. But this weakened immune system can sometimes allow dormant, virus-driven B cells to suddenly multiply out of control, which creates lymphoma lesions in the brain.
Okay, so in this specific case, the patient undergoes surgery to remove a brain lesion, but then on the follow-up PET scan, the clinicians notice a sudden, dramatic loss of metabolic function in a completely different, distant part of the brain.
And if you don't understand the neuroscience, you might panic and think the lymphoma has destroyed a whole new area.
Right, but the clinician must consider the concept of secondary diaskesis.
Secondary diastasis, yes.
So the brain is this intricately networked electrical grid, right? Neurons in one hemisphere are constantly sending signals to neurons in the other.
Constantly communicating.
So if a surgeon cuts into the right temporal region to remove a tumor, they are physically severing those communication wires.
Yeah.
The neurons in the distant, unoperated part of the brain suddenly stop receiving their normal input signals, and deprived of that stimulation, their metabolic activity just plummets.
It's like turning off a power station in one city, and suddenly the lights go out in a neighboring town.
Exactly. The neighboring town isn't destroyed, the power was just cut.
Right. So distinguishing between a dark area caused by the spread of multifocal lymphoma versus a dark area caused by the surgical severing of the neural network, that is where the art truly meets the science of diagnostics.
And speaking of diagnostics, I think the most profound example of mapping a complex systemic crisis in the whole book is Case 48.
Rhodheim-Chester disease,
Yeah.
ECD.
Yeah. ECD is this exceedingly rare multi-system disorder that strikes in adulthood, and it's driven by histiocytes.
Right, and normally histiocytes are just your body's cleanup crew. They're immune cells, like macrophages, that swallow up foreign substances and dead cells.
But in ECD, these cells go totally rogue. They multiply uncontrollably, and they infiltrate multiple organ systems simultaneously.
And because they travel systemically, standard imaging really struggles to grasp the full scope of the disease.
But on a phenotypic PT scan, the pattern is undeniable.
It's very striking. The text details that over 90% of patients show skeletal involvement, particularly in the axial skeleton and the pelvis.
Wow.
Over 80% have massive histiocyte accumulation in their kidneys, and roughly half show infiltration all the way up in the central nervous system.
It's just astonishing that a single PE scan can trace these rogue cells from the bones of the leg into the renal system and up into the brain, providing just one unified map of the entire invasion.
But the authors go even further than mapping. They use a metric called SUV max.
The maximum standardized uptake value.
Exactly. It is a precise mathematical calculation of exactly how much tracer a specific lesion is absorbing.
Okay, so putting a hard number on the appetite.
Right. Now, in ECD, many patients carry a specific genetic mutation called BRAS, and the presence of this mutation correlates with incredibly aggressive, highly FDG-avid lesions in the brain and bones.
Okay, and the book draws a direct predictive line here.
Right, it does. The higher the SUV max number in those lesions, the higher the patient's mortality rate.
Wow.
In one specific image they show, the disease is invading the femoral, head and neck, basically the upper thigh bone. The SUV max inside the histiocyte mass was a massive 19.0.
19.0.
But directly next to it, the adjacent normal bone registered an SUV of just 6.0.
That differential, 19 versus 6, that's not just some trivia fact. It is the real-time phenotypic signature of a biological invasion.
Exactly. It demonstrates that when quantified correctly, PET is not simply a diagnostic camera, it is a predictive instrument.
It quantifies precisely how violently the disease is threatening the host's survival.
It's a complete evolution in how we define illness.
It really is. We started this deep dive by basically throwing away the comforting but flawed idea of a simple positive or negative cancer scan.
We learned that a dark spot on a scan isn't an invisible tumor.
Right, it's a cold warehouse. It's a tumor with just a different metabolic engine.
And we explored the necessity of the lock and key mechanism. You cannot use a glucose tracer to find a neuroendocrine tumor heavily coated in somatostatin receptors.
You have to use dotatate.
Exactly.
And we dissected the biological noise. We saw how a morning workout drives insulin into muscle tissue and how the immune response to a COVID-19 vaccine can literally masquerade as metastatic spread.
And finally, we saw how measuring the exact SUV max allows us to track rogue histiocytes in ECD from the bones to the brain.
It demands a rigorous, deeply analytical approach from the clinician, doesn't it? Every pixel on the screen has to be justified by a cellular mechanism.
It really does.
So if you've been following along, listener, it is time to put these concepts into practice. Let's look at a clinical scenario based on what we've learned.
Okay, let's test them.
Okay. You are reviewing the chart of a patient with a history of prostate cancer. Over the last 6 months, their blood work shows their PSA levels are steadily rising, indicating the disease is active. So, you order a standard technetium 99-meter bone scan to check for skeletal metastasis, but the results come back completely clear. Based on the biological mechanisms we covered in Case 30, what is your next imaging step, and crucially, why?
Think about the treatments the patient is likely receiving and how that alters the chemistry of the body.
Okay, here's the answer. The correct approach is to order a scan using a prostate-specific tracer, such as F18 fluciclovine or PSMA,
Why?
because a patient with rising PSA is almost certainly on androgen deprivation therapy.
And that therapy suppresses the osteoblastic bone reaction that standard bone scans actually look for.
Making the bone scan functionally blind. And because prostate cells are slow glucose consumers, a standard FDG sugar scan will also likely fail.
So you must use a tracer engineer to bind directly to the specialized proteins on the membrane of the prostate cell itself.
Exactly. Understanding that sequence, recognizing when the therapy is masking the disease and knowing exactly which chemical key to reach for next,
Yep.
that is the hallmark of advanced phenotypic oncology.
That's brilliant.
And I think it forces us to ask a massive question about the future of medicine right as we wrap up here.
Okay, what's that?
Throughout medical history, we have categorized cancers geographically by the anatomy they originated in: breast cancer, colon cancer, lung cancer.
Right, based on location.
But if we can now use phenotypic PET to look directly at the metabolic appetite of a tumor, if we can count its receptors, measure its exact glucose demand, and quantify its cellular machinery, well, how long will it be before we completely abandon geographical naming and start classifying and treating cancers exclusively by the phenotypic signatures we see on these scans?
It absolutely points toward a paradigm where the organ of origin matters far less than the metabolic pathway driving the mutation.
The diagnostic waters aren't really murky anymore once you know how to read the currents. We are mapping the living biology of the disease. Keep looking deeper, everyone. We'll catch you on the next deep dive.